Good evening to you all. Welcome to another webinar conducted by SLACD. We have here today Dr. Dilini Vikulaguna. She's a very fresh acting consultant straight from after her overseas training from UK. She has completed her MBBS and MD in pediatrics and DPH. She's talking today on early detection of cerebral palsy, the role of Hammersmith Infant Neurological Scale. This is basically mainly for professionals and those who have some basic knowledge about cerebral palsy will know the importance of this topic because in cerebral palsy, it is of utmost important that we detect it early so that we can apply early interventions to get the best outcomes for these children. So if we take the cohort of at-risk infants whom we have identified the risk for cerebral palsy, there are methods to detect early intervention detect cerebral palsy early. So I think if you remember, Dr. Gamunu did a very good webinar on general movements earlier. This is also, I would suggest you to refer this webinar connected to that because the two together, the general movements and Hines taken together, have got 98% accuracy of predictability of cerebral palsy. I shouldn't talk much because Dilini is going to explain to us about this. Over to you, Dilini. Thank you.
Good evening, everyone. Welcome to the webinar series conducted by Sri Lanka Association for Child Development. First of all, I would like to thank Sri Lanka Association for Child Development for inviting me to do this webinar on early detection of cerebral palsy and role of Hammersmith Infant Neurological Examination. So this webinar is a part and a sequel of the earlier webinar conducted by Dr. Gamunu on early detection of cerebral palsy. So to recap what was presented in that previous webinar, whenever a child presented to us with suspected or possible cerebral palsy, the key message was to don't wait and see, because we know there is a critical window of sensitivity due to neuroplasticity in brain. So to utilize this early advantage, it's very important that we detect early and intervene early for cerebral palsy. Now, early interventions for cerebral palsy means using intense motor learning task-specific approaches with environmental enrichment and family support. And there are mounting evidence to show that these early interventions result in improvements in the motor and cognitive outcomes of children with cerebral palsy, and also this will help to prevent musculoskeletal complications and it will help to elevate parental mental well-being. Now, Dr. Gamunu gave a detailed description on importance of detailed clinical evaluation and the main test modalities we use in early detection of cerebral palsy based on the latest international guidelines. So the first webinar consisted mostly on the motor assessment, which is the general movement assessment, and also the neurological examination, which was Hammersmith Infant Neurological Examination, was introduced to the audience. So based on that sequelae, today I'm going to talk to you about the pathways for early detection of cerebral palsy. And in the latter part of my presentation, I will concentrate on the standardized neurological examination, which is the Hammersmith Infant Neurological Examination. Now, we know the clinical diagnosis of cerebral palsy can and should be made as early as possible because that gives us opportunity to offer diagnostic specific early interventions for infants and also to offer support for the family. Now, in case when the clinical diagnosis is suspected but cannot made with certainty, there's a window that we can make the interim clinical diagnosis of high risk of cerebral palsy, where we still can offer early interventions and family support until the confirmatory diagnosis is made. Now, to make the diagnosis of cerebral palsy, we need to demonstrate a motor dysfunction and either abnormal neuroimaging or suggestive clinical history in any child present to us. Now, the motor dysfunction is demonstrated by either demonstrating reduced quality of movement, which is mainly utilizing general movement assessment, or we can show that abnormal neurology using the standardized neurological examination, which is commonly used is Hammersmith Infant Neurological Examination. And also, the infant's motor activity should be substantially low below the age expected. In addition to this motor dysfunction, there should be either a presence of abnormal neuroimaging or a clinical history suggestive of risk factors for cerebral palsy. Now, the international guidelines give two pathways in detection of cerebral palsy. In the early infancy, when a child infant present to us below 5 months of age, we use same principles. So when there are newborn detectable risk factors, namely prematurity, hypoxic ischemic encephalopathy, sepsis. There are a number of risk factors like this. Together with these risk factors, if we can demonstrate motor dysfunction through general movement assessment, in combination with either abnormal neuroimaging in a modality of MRI scan or abnormal neurological examination in a way of Hammersmith Infant Neurological Examination, we can make the diagnosis of cerebral palsy or high risk of cerebral palsy. Now, all these assessments have high sensitivity in predicting cerebral palsy, and the most sensitive assessment would be general movement assessment. Now, after 5 months of age, you still go by the same principle. So there will be infant detectable risk factors, which mostly concentrate on a motor delay or presence of asymmetry. And the motor dysfunction should be demonstrated using standardized motor assessment. So the international guidelines suggests using either Alberta Infant Motor Scale or developmental assessment of young children, and there are many more motor assessments mentioned. And these two combined with abnormal neurological examination, which again by using Hammersmith Infant Neurological Examination, with or without neuroimaging, you can still make the diagnosis of cerebral palsy. Now again, the motor assessment and the neurological examination have higher sensitivity level in predicting cerebral palsy even after 5 months. Now that brings us to the second part of my presentation, where I'm going to concentrate on the standardized neurological examination explained in the current early detection guidelines for cerebral palsy, which is the Hammersmith Infant Neurological Examination, or in short, HINE. Now, HIND is a standardized clinical neurological examination, which can be conducted in any infant between 2 to 24 months of corrected age, and it's an easily performed test and accessible to all clinicians through a free website. This assessment can be completed in 5 to 10 minutes. So the HIND is chosen as a standardized neurological examination because over the years, there are mounting evidence to show that sequential use of HIND allows identification of early signs of cerebral palsy with high percentage of accuracy with sensitivity and specificity. Now, also it provides objective information on motor severity and distribution of cerebral palsy, which is very valuable. Other than the motor abnormalities, HIND has a predictive value to predict the cognitive outcomes and other non-motor outcomes of the infant. And despite the level of clinical experience, it has shown good inter-observer reliability. Now, this allows us to assess any child in longitudinal manner, including checking the effect of our intervention. Now, Hammersmith infant neurological examination, as I said, very easily performed in your clinic setting, and it takes only 5 to 10 minutes. Now, it can either be performed in infant lying in a flat surface, or you can use parents' lab as an examination area to keep the infant more cooperative, especially if in the late infancy. You need few equipment to perform HIND. Mainly, there are some visual targets and a deep tendon reflex hammer, a head circumference tape, and a soft bracket. There are different visual targets used in performing HIND. So the HIND performer has initial part where you need to fill the basic details about the infant, about the name, gestation and age, and depending on that, you are supposed to calculate the corrected age. And also you need to document head circumference. Now, in the HIND performer, there are three main components. First one is the neurological examination, which we are going to score. And there is the developmental milestones, which we are going to mark, but it is not scored. And also there is a part where you need to assess the behavior of that, again, which is not scored. So the neurological examination gives us the quantitative measurement, and the developmental milestones and behavior gives us valuable qualitative information. The neurological examination has 26 items divided into main 5 domains, namely cranial nerve function, posture, quality and quantity of movement, muscle zone, reflexes and reactions. So each item is scored individually from 0 to 3. So the maximum score would be 3, the minimum score would be 0. Therefore, looking at the 26 items, the maximum global score or overall score given for the neurological examination is 78. Now, higher the score, it indicates a better neurological performance. So this is where you put the final scores of HIND once you perform the testing. And note, there is a place where you should mention number of asymmetries, which again gives you very valuable information when it comes to hemiplegic distribution. So the cranial nerve function, which is the first part of the neurological examination, looks at facial appearance, eye movement, visual response, auditory response, and sucking and swallowing. Now, I'll take each item and describe it a little more, and there are some videos that would explain each item as well. Now, in the facial appearance, you look at the infant's face at rest and when crying or stimulated. You look at the symmetry, the facial expressions, and also whether the eye closure is optimal or not. The eye movements and the visual responses are checked with a visual target. So you use a black and white target to check the conjugated eye movement as well as whether the ability to follow a complete arc. Now, if you observe this infant, you may notice that this infant follows the visual target to some extent, and there are times the conjugated eye movements are not observed. There is a deviation of eye. So this infant actually noted to have cortical visual impairment. So the infant did not score the optimal score. The score was 2 for this item. Now, auditory response is again assessed using a soft grasses presented to each side and assessing whether there is a response. And you are supposed to notice any asymmetry when presenting the auditory stimuli again. Sucking and swallowing is best if you can observe it during the examination, or if it is not possible, you need to ask the history from parents. If parent gives a history of poor feeding, cough with feeding, or excessive dribbling without any obvious issues of sucking or swallowing, you need to arrange for secondary assessment, and the score would be again 2. Now we've talked about the cranial nerve assessment. The second part of the neurological examination is posture. Now this is assessed in sitting, lying, and the standing positions. So you need to observe the infant's head, trunk, arms, hands, legs, and feet in these different positions. And the performer gives you a brief description how each item is scored with a line diagram. Now, as you can see, when the infant is sitting, you need to score the head in sitting, whether it's in midline and whether it's straight, and the trunk, whether it's again straight or slightly curved or bent to a side. Coming to arms and hands at rest, you need to see whether the arms are in neutral position, slightly bent. Is there any internal or external rotation? If there's any dysfunction posture. When it comes to hands, whether there is twisting or adducted thumb. So you can see in the middle picture, in left side, the infant has slight internal rotation and twisting of hand. Then you come to legs and feet in sitting, supine, and standing. You need to see whether infant is able to maintain leg position while seated, whether they are bending or whether the legs are straight, and also whether there's internal or external rotation at hip. When it comes to feet, again, whether there is internal or external rotation, or whether there's tendency to tiptoe. So this is leg position in supine. The previous one shows leg position in seated. Now you can see in this infant, there is external rotation at hip, but the feet are in neutral position and the toes are straight. The next part of neurological examination concentrates on movement. So you assess quantity and quality of movement. So this is more or less similar to the general movement assessment, where you see whether the movements are excessive, sluggish, and whether there is good fluency, alternative and smooth movements, or whether you can see any cramp synchronized, spasms, tremors, ataxia, myoclonus, or dystonia, while the infant is spontaneously moving in the supine position. Now, the next part of the neurological examination assesses tone. So there are different manuals described in Hammersmith Infant Neurological Examination to assess tone, and I will discuss each one separately. Now again, the performer gives you a brief instruction using line diagrams and a short instruction, and you need to look at the range of movements and then score accordingly. Now the scarf sign is assessed taking infant's hand and pulling the arm across the chest until you feel resistance. And depending on the position of elbow in relation to the midline, you mark the tone of the arm. So whether when you have hypotonia or hypertonia, you may have a suboptimal range of movements there. Shoulder elevation. Again, you need to lift arms alongside the infant's head and see how the resistance is felt. So there will be no resistance if there's hypotonia, and there will be more resistance if there is hypertonia. Then you check pronation and supination of arms. By stabilizing arm, you use the forearm supination and pronation. Then you go to hip to see how hip adductors, the tone of hip adductors by abducting the extended lower limb and see the angle between them. Now again, you may notice if there's hypotonia, the angle would be more, and if there's hypertonia, angle would be less than 80 degrees. Popliteal angle is checked while the infant is in the supine position and trying to bend the legs over the tummy and see the angle between leg and the thigh. Final part of the neurological examination looks at reflexes and reactions. Again, there are a number of manuals you need to use, which are again very simple to see arm protection, vertical suspension, lateral tilting, forward parachute, and finally checking the tendon reflexes. So arm protection is where when you try to lift the infant from supine position with one arm, you see how the infant raises his other arm to get onto the seated position. Now, depending on whether the arm and hand is extended, semi-flexed or fully flexed, the scores are given. Kicking in ventral suspension is where you lift the infant from under axilla to allow infant to kick the legs, and you may tickle the feet to simulate kicking, and you mainly look at the symmetry of the kicking movement. So the abnormalities would be asymmetry of kicking, or there's no kicking, or there's scissoring. Lateral tilt is done by holding infant around hip and then tilting in lateral plane to see the position of arms and legs. This again assesses whether there is a floppiness or whether there is hypertonia while you perform the manual. Forward parachute reaction is usually observed after 6 months, and you see how the infant uses his arms to protect when forward and downward movement is performed. So that concludes the neurological examination, where you perform all these 26 items and score them from 0 to 3 per item, and the maximum score would be 78. And as I said, the second part, the section 2, looks at motor milestones about head control, sitting, voluntary grasp, ability to kick in supine position, rolling, crawling, standing, and walking. So each item will give you the normal age at which these motor milestones are achieved, and you are supposed to document the reported age and the observed age of these milestones. So this gives us valuable and qualitative information. However, this item is not scored to the final score. Behavior is the third section, where you look at the conscious level, emotional status, and social orientation of the baby, ranging from unarousable or irritable or withdrawn child to interesting, happy, and smiling child. Again, these items are not scored, it just gives you qualitative information. Now, once you score high, how do you interpret these scores? Now, when the early researchers were done in high, the optimality scores, something called optimality scores, were developed to interpret these results. Now, these were performed in low-risk neurotypical infants from 3 to 18 months, and then they had a normal distribution curve. If 90% of infants have a score for each item, and that score was considered as optimal. So whenever you score your hind for a particular infant, the global score is reported as optimal if your infant has scored equal or above the age-specific optimality score defined in research studies. Now, Romeo et al. Did a larger study where they put out optimality scores for each age group for 3 months, 6 months, 9 months, and 12 months. So for 3 months, the optimality score is 67. For 6 months, it's optimal if it is 70 or above. For 9 and 12 months, it's optimal if it is equal or above 73. Now, how do you use these scores? Looking at the literature and the evidence, it has shown that infants who had global scores equal or less than 56 at 3 months, equal or less than 65 at 12 months showed high sensitivity and specificity for development of cerebral palsy. Now, this is again based on Romeo et al. Article. The Novak article, which gave the guidelines for early accurate diagnosis of cerebral palsy, suggests that hind scores at 6, 9, or 12 months less than 73 indicate high risk of cerebral palsy. Based on the Novak article, the hind scores at 3, 6, 9, or 12 months, if it is between 50 to 73, the research has shown it's likely the infant would likely to have universal cerebral palsy, whereas less than 50 score indicates bilateral cerebral palsy. And when the hind is performed between 3 to 6 months, and if the score is less than 60, the infant is likely to end up in GMFDS 3 to 5 levels, whereas 40 to 60 scores indicate GMFDS level 1 to 2. So, ambulant cerebral palsy. Now, it has shown the abnormalities of items of axial and limb tone, movements, and vision were the items that are highly predictable for cerebral palsy. And between 3 to 12 months, movement quality and quantity were the most predictive of cerebral palsy. And it has shown suboptimal Hines scores less than 40 is associated with severe basal ganglia lesions in neuroimaging. So further research has shown and suggested using asymmetry score to detect and diagnose hemiplegic cerebral palsy, where they have a recent article has suggested using a Hines score less than 63 with asymmetry score more than 5 has high sensitivity and specificity to diagnose hemiplegic cerebral palsy. It has also shown that Hines score is correlated significantly with 2-year mental developmental index scores, which gives us the idea about infant cognitive development. So that concludes my presentation today. To summarize what we've been discussing today, we are again emphasizing the importance of early detection and early interventions for cerebral palsy. And there are 2 pathways that we currently follow to diagnose cerebral palsy using 3 principles of abnormal motor dysfunction, the combination of clinical history or neuroimaging to diagnose cerebral palsy. The motor dysfunction is demonstrated using either general movement assessment or Hammersmith Neurological Examination. Hammersmith Neurological Examination is easily accessible, easily trained, and take only 5 to 10 minutes to perform in your clinic setting, and is very reliable in predicting cerebral palsy.
Thank you, Dilini. Thank you, Dilini. That was very comprehensive. Uh, so you have posted the link in the chat, is it?
Yes, madam.
Yeah, I think that was very comprehensive, but to tell you the truth, I'm using AIMS in my clinic. I have tried to do Hines several times, but it's a little bit more complicated. What do you think? Hines is, I think compared to AIMS, it has a bit more of a learning curve. The, and
Yeah.
all that. It needs a bit more time for learning, isn't it? So one has to take a bigger curve than some for compared to something like AIMS score, isn't it?
Mm, to be honest, madam, I mean, if you get used to it, I mean, I'm
Yeah,
not like an expert, but still, I mean, within few trials, you get
Motor
hold of
distribution
the
as well
basic.
as non-motor outcomes of infants.
yeah, I think so.
So, so yeah. So after few trials, you get hold of it, and I think you can really do it within 5 to 10 minutes within the clinic setting, and So unfortunately, I just visited the Hein website, and I think they are uh, uh, doing it again. Like they are reorganizing the website, so they are at the moment not letting people to register for new videos, because you need to register for new videos. But once they have redesigned the website, I think it's freely available for everyone.
That's good news. After some time, yeah. I think that it is really important to get it started. Get started. Start doing this, isn't it? So you have to push yourself to do it, and once when you start, it'll get going. And it is very
Yes.
important to diagnose cerebral palsy, because we mostly have gross global developmental delay in most of our diagnosis, isn't it, Silini? because
Yes.
proper diagnostic tools are not used. So then
And
yeah.
yeah, using a standardized assessment like general movements and Hein gives you confidence to make the diagnosis. So then you will not really end up with query cerebral palsy or global developmental delay. So that
Uh,
is the importance.
it's a long way to go for Sri Lanka. You see, I'm still struggling to do it at LRH, because it has to start from the delivery itself, to stratifying the children, kids, infants as high risk, and then following them up, and um, scheduling these tests in the correct time period, isn't it? So we really need a streamlined program to do this. So I'm very happy that they're taking it up at the Family Health Bureau, and we'll be
Yeah.
able to, yeah, uh, train people and generalize this for all the infants who are born in the country. So hopefully we'll get things straightened up in future.
Yeah, the good news is the
Yeah.
guidelines are coming and the care pathways are developed. So I think that will let us to start the training for the neonatal staffs and the early intervention staffs for Hammersmith and general movement assessments. And I think hopefully what you explained would not be very far away future, hopefully. So within next few years we will be able to streamline things quickly.
That's good. That's very good. So thank you so much, Dilini. It's a most wonderful presentation, very clear and precise. Uh,
Thank you,
we
Manu.
yeah, from the Council of SLACD, I would like to thank you. And I must not forget our media sponsors, Allergan. They are sponsoring all our webinars. Thank you, Allergan and Dr. Emil. He's the person behind all our, webinars. He's facilitating this. Thank you, Dr. Emil. And we would conclude tonight's talk. Good night, everybody. I hope you will go back to Dr. Gamanuhiwaitana's talk as well, and learn the two together, and try to, you know, learn and do it at your center. Thank you very much. Good night.
Thank you.